What you're about to watch is an ABCDE assessment of an unwell adult performed by myself in the Clinical Skills Centre with a simulated patient. This is by no means a perfect assessment, but gives you an example of what my typical process would be. The clinical scenario here is that I've been asked to go in and see Daniel, who is a young man who has presented to the emergency department with acute shortness of breath and left-sided chest pain this morning. You will often receive some kind of priming information such as this in an OSCE and also in clinical practice, such as a triage note or a handover from a colleague.
Hi Neil, I'd like you to go and see this patient please. His name's Daniel. He's a 22-year-old gentleman who's presented this morning with quite acute onset of left-sided pleuritic chest pain and shortness of breath. He seems quite distressed and a lot of pain just now, so could you perform an ATE assessment and then let me know what you're thinking?
Initial introductions to Daniel suggest that he is obviously in respiratory distress. You can see that his respiratory rate is elevated, as is his work of breathing, but fortunately he is able to chat to me and his airway seems to be clear. He's speaking in shorter and interrupted sentences because of his breathlessness, but there are no added sounds to his airway either. Here quickly in my ABCDE assessment, I have already assessed that his A is likely patent and self-maintained and not acutely threatened. A very quick explanation of what my assessment will involve is important for Daniel to put him at ease and let him know what the process is, but also important for me as it allows me to get my head into gear and tell myself exactly what I'm going to do. This is a useful technique in OSCE examinations. In performing my B assessment, you'll see that I auscultate the anterior aspect of the chest rather quickly and do a 6-point top, middle and lower end of the chest, as well as bases, rather than a full 12-point with apices and examining the posterior chest. What I fail to do in this circumstance is expansion of the chest and also percussion of the chest. This is an omission on my part, A, because of the haste of the situation, and B, because I've clearly identified an absence of breath sounds in his left hemithorax. This absence of breath sounds, accompanied with his history, suggests a potential pneumothorax. In OSCE examinations and in postgraduate examinations and in advanced life support courses, teaching is that one should check the trachea to be central. In clinical practice, however, clinical deviation is extremely rare. Having identified a potentially life-threatening B problem, grabbing a pulse allows me to do a very quick, rapid C assessment before moving on to gathering more B information. Grabbing a patient's radial pulse will tell you a great many things. It will tell you their peripheral temperature, if they are cold, clammy, shut down. It will tell you the heart rate as an approximation. Is it slow, is it normal, or is it fast? It will tell you whether it is regular or irregular, and it will tell you the character. Is it thready, is it weak, or is it bounding and strong? Alternatively, in very, very unwell people, the radial pulse may be absent, in which case it would be important to check a more central pulse, such as a brachial or a carotid. As part of my B assessment, oxygen saturations show that Daniel is acutely hypoxic, and therefore it is important to administer supplementary oxygen as quickly as possible. There is, in reality, only one correct amount of oxygen to give in OSCE situations and in emergency settings, and that is 15 litres of non-rebreathed oxygen via a non-rebreathed mask. This high-flow oxygen can then be titrated down to effect to reach appropriate saturations. This includes in COPD patients where hypoxia will kill you faster than hypercarbia. To complete my C assessment, I've put on a blood pressure cuff on his right arm and started the blood pressure reading on the machine, and I'm also applying a 3-lead ECG. You will hear in the time it takes to do this, having applied high flow 15 litres of non-rebreathed oxygen, the audible tone of Daniel's saturations trace is increasing, and that tone increasing tells me that his oxygen saturations are improving. In clinical practice, this would likely take a little bit longer. Something I have failed to do here, which is typically extremely helpful in identifying a patient's fluid status and how unwell they are, is a central capillary refill time, or CRT. This is performed by placing a finger against the sterile body for 5 seconds and then releasing that finger and counting how long it takes the colour to return to the skin. In emergency situations, especially when somebody is tachycardic and hypotensive, It is never incorrect to ensure that you have adequate venous access and draw bloods. In this case, it involves a cannula in the ACF, as wide bore is appropriate for the clinical situation. In OSCE scenarios, with anybody who displays signs of shock, the answer should be wide bore venous access in both ACF. Fluid resuscitation in the acutely unwell adult is a very different topic and a much larger topic, one that you will study throughout your undergraduate and postgraduate careers. Typically though, what you will see us use and what you will be expected to use in OSCE situations is 500 or 1000 mL of crystalloid, either saline or Hartmann solution. This is sometimes reduced to 250 mL in the elderly and in those with congestive cardiac failure, but if in doubt, 500 or 1000 mL given as a stat bolus run through as quickly as possible. I now move on to my E assessment and examine and expose the abdomen. Moving on to my E assessment here, because I have already established that Daniel is cognizant and speaking to me normally. In terms of an ACVPU cognition scale, he is alert. I have not performed a peripheral blood sugar, as I did not have the equipment available at the time of filming, but in inserting a peripheral venous cannula, you can always take blood off of the back of this to perform a quick BM. Another important part of my D assessment would typically be a pupillary response if I had any concerns whatsoever for a person's level of consciousness. My E assessment, as well as an abdominal examination and an examination and exposure of the chest and abdomen, also includes an examination of the lower limbs. This is extremely useful for both an E assessment to check for signs of infection, signs of swelling, but also from a C point of view to assess the peripheral pulses in the feet and in the ankles, if there is any significant edema suggestive of congestive heart failure, or unilateral swelling and redness and tenderness within the great deep veins, which suggests deep vein thromboses. Having completed my ABCDE assessment here, I now move on to take a quick sample or ample history from Daniel. In my mind, I already have some idea of what the diagnosis may be, but in gathering brief but important information, I'm able to cement that suspicion. To follow this, I'm explaining to Daniel what my examination findings are and what my clinical suspicion may be. This is vital in clinical practice, as patients who are this unwell are often extremely frightened and would like answers as quickly as possible. I have identified a potentially life-threatening pathology and would like to move on to treatment as quickly as possible. Important for your OSCE examinations, however, are having made important interventions such as the application of oxygen, inserting an intravenous line and giving intravenous fluids. It is important to go back and reassess your patient from A, B, C, D and E point of view to make sure that any interventions you have made have been therapeutic and nothing has deteriorated or changed. Hi Neil, so I've been to see Daniel, who's this 22-year-old man who's come in with sudden onset left-sided pleuritic sounding chest pain and shortness of breath. I've done an A to E assessment on him and I've found that he's tachypneic at about 35, his saturations were about 88% on room air. They've come up quite nicely with some non-rebreathe 15 litre oxygen. His blood pressure was a little bit low, so I've popped a line into him, drawn some bloods, and I've hung some fluid up as well for him. I'm a bit worried on assessing his chest that there's no breath sounds on the left hand side and that the expansion of the chest is unequal with the left rising more than the right. I do wonder if he has primary spontaneous pneumothorax and we'll need to get a chest x-ray and assess whether or not we need to aspirate or put a drain in and get him admitted under the medics.